Khokhar sir to give his talk on Intra Lenticular lens aspiration for pediatric subluxation, a new technique which he has devised and published also.
Thank you, Namrata, for those words, and thanks for letting me in, because I think Dr. Tityal is waiting in the gymnasium. We're going to have a TT match, so I have to rush down from here. Thank you. Okay, so what is it all about? There are two kinds of subluxation which we all see. One is a traumatic, the other one is a congenital. So recently we realized that we're getting lots of. My slides are visible, Namrata?
Yes, perfect.
And I'm audible enough?
Yes, yes.
Okay, perfect. So this is the place where I'm working, and this is the place, our alma mater. So I'll be talking about the intralenticular lens aspiration, especially in the pediatric subluxated ones. The two groups we all know, traumatic and a non-traumatic. The traumatic ones are typical because you get to get a hyphema, there's a tear in the sphincters. But at the same time, the other part of the zonules, which are not broken, are strong enough to hold the lens. So you can put a CTR and get away with that. Whereas if you come to patients of the congenital variety, which are Marfan homocystinuria and microsphericchia, all these patients will have zonules which are progressively breaking down. So this is a progressive disease. So that means just putting a CTR inside is not an answer. You have to put it to the sclera, stitch it to the sclera, and that all comes later. First, you have to have a safe technique of removing this lens out of the eye without making the incision to go big. So I'll just stick to the salient features. I think, okay. All right, so this, you can have a subluxation going up, down, coming all the way anterior, or you can see a spherophakia here, which you can see the clear lens, but these lenses have to be taken out because the refraction comes is about a 16 to 18 to 20 with a loss of cylinder in these eyes. So the mother of all the subluxation, I call them as a spherophakia because lenses are clear, but they have to be taken out, and the bag cannot be fixed in most of these patients. Okay, so we did a study on the spectrum of the surgical outcome of the spherical which was published in 2017 in London. And we found out that majority of these patients actually had consanguine marriages, especially for the spherical patients. And most of these patients needed to be left aphakic. Okay, so in the good old days, we used to, in spherophakia, we used to put a CTR and stay happy. I mean, we used to feel that we've done a great job. But this was a patient which we published in 2003. In 2008, the patient came to us with the lens bag and CTR all fallen into the vitreous, had to be taken out, and a scleral fixated lens was put in this one later on. So how did we start doing this? Now, this is one of the techniques in which what we're doing is we're doing the rhexis. This is the case of the spherophakia. And once your rhexis is done, I think quite a bit of your worry is over. Then you do a gentle hydro in these ones. This surgery actually was done in a place called Westmead Hospital, which is very close to Sydney Central. And once your bimanual is done, your aspiration done, you can put a Morser's ring. The advantage is the moment the Morser's ring goes in, the bag, which is becoming anterior posteriorly big, starts going flat, loses the AP diameter, and it starts going behind the iris. But that is not the end of the surgery, because that is where if you leave the lens, it might stay good for a few years, but it'll come back with a vengeance, and it might be coming in the end, falling out of vitreous. So what you need to do is you need to put something, a segment or a Sioni. Since we already put in a Morser, a Sioni segment goes in, Hamlet segment goes in, and you put it in. It's like putting a coat on your hanger, and it goes and stays put inside the eye. Okay, so this is one group in which you actually put scleral fixation of the bag to the sclera, and the lens goes into the bag. If you see a follow-up in the patient 1 year after Sioni and one without Sioni, you can see more contracture without the CTR. Okay, so I think I'll skip these ones. So what is a new technique we generated a new technique which was in 2018, and it's modified lens aspiration. There were certain techniques before, but they were not answering all the things. So what was known before, that interlenticular lens aspiration is good technique for Marfan subluxated without opening the section. But they used bimanual aspiration first, and then they used the cutter to go in and eat it up and do the procedure. What we did was we made 2 stab incisions going all the way from the limbus all the way into the lens, and with the IA cut mode of the cutter, we finished up the entire surgery, and switching over to the cut IA to eat of the bag. I'll show you the videos now. So any luxation which is more than 9 clock hours and where you're sure you won't be able to fix it, and spherophakic patients, I think this is one of the very good techniques which have come up. So I think okay, let's go to the video now. Okay, so see, this is a subluxated patient, and it's a clear lens. So once it's a clear lens, the chances that it's a spherophakia, and this patient had a family history. There were 3 guys in the hierarchy which had spherophakia, so we were sure that's the spherophakia. So you see, I gone with a stab all the way into the lens. Now I got 2 openings. So at this stage, I'll go with my aspiration port from one side, I'm putting a dash of adrenaline. I do a little hydro. This was the initial few patients. Then one aspiration and haptic both going into the bag, and we gently aspirate the cortex. And what you see at the end is entire cortex is gone, and of course the opening you made has gone bigger. Then you switch over to the kata mode without coming out of the eye and losing the chamber, and you can actually create a full aphakia. And once this eye is there, then it's your call. You can do a scleral fixated lens, you can do iris claw lens, and you can do anterior chamber lens, whatever is your fancy. So this is the technique. Now this is another patient in which there's a subluxation interior. You see, I come from the side port going all the way into the lens, then coming from the opposite side, again going all the way into the lens. Now here, a little hydro. Even if you don't do the hydro in these patients, the cortex is so soft that you can take it out very easily. This was a 6-year-old child. Now I'm going inside the bag. You can see both my probes are inside the bag. And once I start aspiration, I can eat up the entire cortex, and the bag is still intact. So the bag, either you can eat it up, and in this case, I pulled it up with the forceps, and wherever I'm pulling it off the iris, you can see there's a ooze marks which are coming. Again, this patient is a good aphakia now, and it's whatever you want to plan, you can plan it in this patient. Similar technique is similar in a few more cases of different proportion. And what do you do afterwards? Now, this is one of the ways which we can rehabilitate is, this is the patient in which put an ACR in. This patient is 10 years of age, and most of my corneal surgeons are not happy with my putting an AC lens. So we stop putting this one now. We do a iris claw with a retrofixation. I'll show you one video that also. So this is what you do. You have to go inside. And if your sizing of the anterior chamber lens is good, these Kelman multiflex lenses are pretty good lenses, but your sizing has to be very accurate. If the sizing is not good, then they can get in trouble. And this is how it's at the end of the surgery. Now, this is another patient. And this was air-assisted anterior chamber implantation, which I think Tushar Agarwal, who's my colleague at the RP Center, and we came out with, Namrata also was part of the study. And this is another case, I think this is the last one, in which after aphakia has been created using a technique by 2 openings only, you can see 1 opening here and 1 opening here, and everything is intact. Then you make 2 stab incision going at a tangent, and then you make a 3.2, which goes to 5.2 for an iris claw lens. I'll just jump up a little bit, and that's the lens inside. So lens here has to go upside down. That means the convexity has to face downwards and concavity has to be superior. I hold the lens firmly with my lens holding forceps, go behind the iris, and you can see the impression of the haptic coming here, and just tack it in, and it goes in as easy as it looks. Then when you come for the other side, put Helon again in the front, hold the lens. The trick is to hold the lens firmly with the forceps. Once your grip is firm, you can actually twist it up a little bit, and you get an indentation on the iris. And once the indentation is seen, you just touch it and it goes. You might struggle in few patients, but after 5-6 patients, you're as good as anybody else. You put the suture and you close it up, and that's how it looks at the end. There's no need to do a PI also, because you're putting the lens upside down. So it's not going to get captured at all, even if you want it to be captured. Okay, so the choice is, as I said, for the lesser subluxation, you can do a CTR or a CTS. But anything which is more than, say, 4 to 9, maybe more than 9, it's best to do the technique which I said, using just a cutter and going in and finishing it off in one. Thank you very much.